Can someone check the live stream?
Yes, sir. I'm just checking in. As of now, it's only showing. Yes, sir. It's live.
Okay, good. So good to go.
Siddharth, can you hear me?
Yeah, ma'am.
Sid, you just have to. I don't know if I can give you. Oh, unless I make you a host. Okay, okay. And I was just trying to put somebody to do this this unmuting work when automatically the mic unmutes, but it looks like only the host can do, and this account has got just one host. Okay, I'll see Sid, what can be done.
Oh, okay.
Okay, can someone just check the audio quality?
Just mute everyone and then it's already starting. We're getting a lot of voices.
A request all participants to keep your mics on mute so that it doesn't affect.
Rizwana, you can keep talking, Rizwana. Then people.
Yes, sir. Yes, sir. Yeah, audio quality is fine, sir. So we have another minute for the program to begin. Yes, TC, you can give the housekeeping announcements. Yes.
Yeah, the questions from YouTube will be followed up by JJB sir. Am I right? Any questions from the YouTube? Will be posted
Any
to my
questions? Chat? Yeah, sure. I mean, I have also kept it open, TC. I will also copy and paste it in the chat.
Sure,
yes.
Just to confirm that.
Rizwana and Tamil
yes, sir.
I cannot switch screen because my screen is shared.
Okay.
So anything you people have to manage. Basically, I'm just getting all the fed through Zoom and I'm sharing it.
Done. So it is I'm sure you're going
I'll
to
do it. I'll do it. This.
Right.
Yes,
right.
yes.
Good evening. Are we good to go, Riz? Can we start?
Yes, please.
Wishing you all a very good evening. First of all, I request all the participants to keep yourselves in mute. And if you have any questions or any suggestions at any point of time, kindly put it in the chat box. And now over to the session. Wishing you all a very good evening. And myself, Tamil Shuda, Head of Education Committee of OATN, I take immense pleasure and welcome you all gathered here virtually on behalf of OATN to our beloved Dr. Rajeswari Mahadevan's first memorial oration. We are sure that there is no better way to remember our beloved Raji and to make our contact lens queen proud. I invite Ms. Saranya, Education and Core Committee member of OATN, to give the welcome tribute to Dr. Raji and also to introduce Optomrupam Sinha. Over to you, Ms. Saranya, ma'am.
Yeah, thank you, Tamil. Good evening, everyone, and welcome to the first Dr. Rajeswari Mahadevan Memorial Oration organized by the Optometry Association of Tamil Nanbargal. I have been given the privilege to introduce Dr. Rajeswari Mahadevan. Raji, as we all know her, I'm sorry, I find it difficult to say Rajeswari Mahadevan. A great friend, a mentor and guide to many. Her smile would just light up a room when she walked in. A very well-dressed and a beautifully organized person. I think this is how I remember Raji. a consummate professional through and through. She graduated from ESO in 1998. She did her MPhil in 2002 and PhD in 2011, all in contact lenses from BITS. She has a number of firsts to her credit. The first PhD in contact lenses in India, the first to get the Asia Pacific Educator of the Year Award, Asia Pacific President of IACL, Executive Board Member from India, etc., etc., etc. You know, even during school, she was a very sincere student, a peacemaker of sorts, very focused. While the rest of the students were trying to figure out college life, she was busy figuring out publications and presentations and how to go on to do what next. And I think that was something that always stayed in my memory. Her journey in the field of contact lenses, basically an area of optometry, which she was extremely passionate about, is lined with achievements and awards and lots and lots of fellowships. Just to mention a few, she is a FIACL, fellow of the Scleral Lens Society. She had a Prose Fitting Fellowship. She was the fellow of the American Academy of Optometry. Again, like I said, the president of the Asia Pacific IACL region, the IACL executive board member, and so many more. I mean, I just can't stop telling you how many more she had. It looked like she was trying to compress everything into whatever, you know, the time that she had. She proved over and over again that with a lot of focus and determination, one could really achieve great heights in the chosen field. And what was really amazing is that she could balance both work and family life beautifully. She gave equal importance to both. And maybe in our own way to carry on her legacy forward, OATN had organized a series of events, the case report writing workshop, the Oracle quiz, and all of this culminating in this memorial oration. We have 3 speakers here today, all of those who knew Raji and were a part of her journey in contact lenses and in life. So once again, welcome to the first Dr. Rajeswari Mahadevan Memorial Oration. And on a personal note, when I had to, you know, initially I was running the contact lens department at SN, and when I had to leave and I was like really, you know, upset about leaving SN, it was for personal reasons. When Dr. TSS gave me her name, my smile would have lit the room because I knew I was handing it on to the right person, and I think I did the right thing at that point. I just wish she was here with us, but you know, I'm just so happy that she did what she did, and she touched so many lives. So before I get all too sentimental and upset, let me go on to introduce the first speaker today. Rupam Sinha is going to give us a small talk on his interactions with Raji. So if you ask Rupam what he thinks of himself, he'll tell you he's an optimistic and a hopeful optometrist, a seeker, a learner, believer, dreamer, and explorer. I absolutely believe that every one of those adjectives, you know, really describe Rupam for what he is. A fitness freak, he runs, he cycles. He also does all sorts of martial arts. He's now learning Kalaripayattu for all, you know, just so that we know. Professionally, he's working, well, he's been through almost all the different aspects of what an optometrist could do. He's worked in a hospital, he's worked in a retail, he's worked as a consultant, he's done sales and training, he's worked as a business manager. So right now he's working on teaching people about contact lenses and myopia. And at the moment, he works as the professional affairs manager for contact lenses with Alcon. His special area of interest is dry eye and ocular health. And he says he loves to help others see as brilliantly as he is seeing with contact lenses. I think his philosophy matches Raji's. anybody can rise above their circumstance and achieve success if they're dedicated and passionate about what they do. And that's why we have Rupam, you as our first speaker today. So welcome to the forum, Rupam. Over to you.
Thank you so much. Thank you so much, ma'am, for that kind introduction. And I'm slightly outdoors, so I'll stop my camera and I'll speak about Raji with all my heart and soul, as I have known her for some years. I was fortunate to know her for some years, and it gives me goosebumps to speak about her. So I'll just stop my camera and start speaking about Raji. And forgive me if I pass my time by 2 or 3 minutes, because it is very difficult to summarize my interaction with Raji in just 5 minutes time. So I'll try to do it within 5 minutes, as Raji would have always expected people to finish their talks on time. But if I take 2 or 3 minutes, I apologize beforehand for doing that, right? And I'll just jump on to what I know about Raji. So first and foremost, good evening, everyone. And thank you, OATN, for giving me this opportunity to share my experience about Raji. Well, I sometimes call her Raji. I sometimes call her Dr. Rajeswari, right? So who is she for me? Let me start by saying that she was no less than a legendary sports star like Sachin Tendulkar or like Rajnikant to me. Now, why do I say that? Why do I say that she is like a legendary? I think so. Why do I say that she is like Rajnikant or Sachin Tendulkar to me is because like them, she was best at what she did and also represented India in many global forums. And with me, her relationship was also like probably the relationship I share with Sachin and my relationship that I share with Mr. Rajnikant. I don't know them personally. I neither knew Raji personally, but I was a fan of her work. I was fan of her professionalism, and I used to follow her like I do these great superstars and legends in their legendary field. And if you ask me, I was slightly fortunate to have interacted with Raji on various occasions, on various forums. And what have I learned from that? So first, let me tell you that, I first met her in October 2014 in an IICL meeting in Mumbai. And my last meeting with her was in February 2020 in Bangalore during Narayan Netralaya Contact Lens and Imaging Symposium. And if I can just tell you about Raji's mission statement in her own language, she used to say that she likes to practice, she likes to innovate, she likes to educate, and she likes to standardize eye care everywhere. Practice, we all know what a great clinician she was. To innovate, well, she was a researcher of a class entirely. To educate, well, you can ask the students. And I was able to interact with few of our students during 2018 when we had a conference called as Force. And her students will always speak very highly about her and what she did for them. And she was a strong advocate of standardizing eye care everywhere. So she was initially a clinician who was a fantastic educator, who turned into a researcher and later advocated and standardized or tried to standardize eye care across optometry and across all fields. And she used to believe, and this is her own words, she used to believe that every eye touched is considered as a life touch. Just imagine, close your eyes and feel the power of this statement as an optometrist, as an eye care practitioner. Every eye touched is considered as a life touched. And because she was a contact lens practitioner, she always believed that contact lenses is not just for cosmetic purposes, but the functional and emotional benefits of both soft contact lenses and specialty contact lenses have life-altering impact on the patients they are fitted to. And she was so good at fitting contact lenses and changing lives. I was fortunate to visit her clinic multiple times as a role for my professional affairs in various companies. And I was also fortunate to receive a book that she wrote on troubleshooting signed by her. And I treasure that with all my life. And she used to, often speak so openly about contact lenses. She always used to, greet you so well. She was so humble and she was so down to earth. Now, other than optometry, and I know I am too small to speak about her optometry journey or her optometry career. I am just a follower of her mission that I told you, and I also share the same mission like her, to participate, to innovate, to educate, and to standardize eye care. And I also believe in what she believed, that every eye touched is considered as a life touched. And I have so many things that I learned from Raji. There were so many things I would have loved to learn from Raji, which did not happen, but her 44 years of life that she has spent on this earth, it was so fruitful and it was so nice. And I was so blessed to know her between 2014 to 2020. I cannot express my gratitude towards her in words. I later saw her in 2018 during a competition called as FORCE, which stands for, Ocular Research and Creativity Event, which is a competition that is done on a global platform. And she, along with Jude, who was a student at that point of time in Shankar Nethralaya, actually won the nationals and went on to become third globally. And again, this time not her, but a student was trained enough to put India's name on the global platform. And if you ask Jude, he would tell you that, Raji even anticipated all the questions that are going to come. She knew, or probably she anticipated in a 100% manner that what questions would come, what cross questioning would happen, and shot Jude to the limelight of, representing India in FORCE along with 14 other countries and becoming third. That shows her skills as a researcher, as an educator, as a contact lens practitioner. So that was what mesmerized me when I learned from Jude that even she anticipated all the questions that are going to come. That's a level of preparation for her and her students. Now, other than optometry, Raji and I had another common interest. And that common interest, as you all know, is running. She started running, and if I remember correctly, she started, running long back and much before than me. And in 2016, she finished her first half marathon. That's 21 kilometers. And in 2016, I was just running 5 kilometers. And she said, no, you can easily run a half marathon. If you have any problem, please get in touch with me. And I'll let you, talk with my husband, Ganesh sir, and he can help you about how to run better. So that, and I'm very sure there is another person in Alcon now called as Manivel Raj, and Manivel will tell you that Raji actually pushed him to run marathons. So anything she did it with so much of heart and passion, and she was always eager to help. She almost ran 5 pinkathons. She ran around 5 pinkathons, which is for upliftment of women. And I'm also associated with Pinkathon, getting inspired by Raji. So my wish, and I always often told it to her, even in 2020 when we met, she said, I'll plan start running 5 kilometers. And I said, ma'am, it is my wish that one day we will run Chennai Marathon with you and Ganesh sir by the side. And I think that won't happen. That won't happen ever. So the last but not the least thing that I would like to tell about her is, before I get too emotional, is that, she never shied away from giving her comments about social condition, about betterment of human being. And she was always vocal about her opinion about any social cause. And that is what you look into a human being, right? She was sensitive. She was a fantastic human being, a fantastic educator, a teacher, a health conscious person as well, because she used to run so much. And my sincere request to OATN going ahead, and even to Rizwana, if she's here and she's listening to us, that let us make 9th September as Raji Running Day for awareness of cancer. And that is my proposal to OATN and to Rizwana. And like Ganesh sir, this year I'm also running 100 days of running. And my this year's of entire 100 days of running is dedicated to Raji. And I hope Raji's life motivates you. Her mission statement stays with all of you. And we are able to standardize eye care everywhere. And we believe in the power of contact lenses, believe in the power of optometry to alter people's life. My respect to Raji. She'll never be forgotten. She'll always be remembered. And my support, my respect, and my love to her family. May they be stronger each year. With that, thank you very much for giving me this opportunity again. And we can never forget what Raji did for this profession and how she touched many lives, including that of mine. Thank you very much. And I think I have been able to finish it on time.
Yes, Rupam sir, thank you so much for sharing your cherished and amazed memories of our beloved Dr. Raji. I can still see that you're really still awestruck about Raji's qualities, both as a professional and and on the personal front, from the way you express yourself. And this has taken me back in the memory lane of being her student too. And I would also like to thank you for the proposal that you have put forward, the Raji Running Day. The OATN will sure consider it. Thank you, Rupam, sir.
Thank you, ma'am.
The representatives from our sponsors, Silver Line Laboratories, due to some unavoidable circumstances, are unable to join us today. However, I take this opportunity to thank them, the Silver Line Laboratories, who are an upcoming contact lens manufacturers and solution providers for all contact lens practitioners. They are into manufacturing RGB contact lenses, bandage contact lenses, corneal clear lenses, and cosmetic contact lenses in a wide variety of colors. They are competitively priced and delivered across the country. And once again, I thank the team of Silver Line Laboratories for their sponsorship. I call upon Dr. Rizwana, President of OATN, to introduce a special guest for the evening, Dr. Susan Gromacki. Over to you, Riz.
Thanks, Stacey. I think Dr. Susan, because we are just going a little ahead of time, Dr. Susan should be joining with us anytime. We are 9.5 hours apart. So before Dr. Susan comes in, I'm just checking in the participants. She has joined by any chance. So anyway, in another 2 minutes, she will be here with us. But before that, I would like to ask Yashwant sir if you would like to share any of his memories with Raji until Dr. Susan joins with us. Dr. Susan is there.
Yes, she's joined.
Hi, Dr. Susan. Good morning to you. Can you hear us, Dr. Susan? I think you are on mute. Your mic is on mute, so.
Yes, I can hear you.
Okay. Okay, so good to see you on a
Thank
Sunday
you.
morning.
You as well.
Oh, thank you. Thank you. So just to give you a brief, Dr. Susan, so we have the Optometric Association of Tamil Nanbargal, which is the association in southern India, in Chennai, that represents the legal body for optometrists in the southern part of this country. So we are observing Dr. Raji Memorial, as you would have understood by this time. And then so we have some of the core members who've joined with us through Zoom. And then there is also people who are watching us live on YouTube, on our YouTube channel. So we have participants on either end. And so it's so good to see you. And it's time to give you a formal welcome. So can I go ahead and then do the welcome for you before you start your talk for the day?
Yes, absolutely.
Oh, thank you. Thank you, Dr. Susan. So okay. So it's so good to have Dr. Susan Gromacki with us today for the OATN's first Dr. Rajeswari Mahadevan Memorial Oration. So Dr. Susan Gromacki is an internationally recognized clinician, lecturer, and author on the topics of cornea and contact lens with over 28 years of expertise. And she is the director of contact lens service of the First Sight Vision Care. And she's presented over 675 professional lectures and publications. And she served on the editorial board and is a contributing editor of Contact Lens Spectrum, Review of Cornea and Contact Lenses, Contemporary Optometry, and Contact Lenses Today. And she served on the National Board of Examiners in Optometry that composes and oversees the written examinations to ensure the qualifications of new optometrists in the United States who would want to enter the practice. And she's only one of the 21 doctors worldwide to earn both a fellowship in the Scleral Lens Education Society and the prestigious diplomate in cornea, contact lenses, and refractive technologies of the American Academy of Optometry. And she's continuing as secretary treasurer at the CCLRT division of the AO. Recently, she was named one of the world's top optometrists in the year 2020. She received the 2018 Albert Nelson Marquis Lifetime Achievement Award, and she was also named as one of the most notable alumni in the 100-year history of the Ohio State University College of Optometry, of which she is also a proud graduate. So now coming over to the association between Dr. Susan Gromacki, Raji, and myself. So many of us who were in close association with Raji always knew that Raji would always aspire to grow to greater heights. And when it comes to the diplomate of the American Academy of Optometry in the cornea, contact lens, and refractive therapy section, I personally would say that that was like Raji's dream, because from 2015, right after we conducted an international conference, both of us were aiming to achieve this accolade, Raji in the contact lens section and myself in the binocular vision section. So we said we're going to be doing this. And so Raji was working so hard towards this, and Dr. Susan Gromacki was the then chair for the CCLRT Diplomate Committee. And every time Raji gets an email from Dr. Susan, she would be so excited because the process is such a rigorous process, a long process. You will have to submit case reports and then take up exams and then viva. And then, so as Raji, she got enrolled into the diplomate, she was almost like going through this process. And that's when Raji was diagnosed with her cancer. And, but even then, Raji was, of course, as we all know, Raji never gives up, and Raji is all determined to achieve what she's always wanted to achieve. And so Raji continued to work towards this process, and she was scheduled for the diplomate oral exam in the 2020 October, which was last year. And so Dr. Susan indeed wrote to Raji saying that, we have your oral exam, and then there's a time difference, and what do you want to do, Raji? And then Raji says that's the time when Raji was on to her sort of peak period of taking all the treatments for cancer. And then Raji writes back to Dr. Susan saying, I will take care and I will be there for the exam. And rest is history. But after Raji passed away, Dr. Sandhya, Raji's own batchmate at the elite school, made a recommendation to Dr. Susan, and we made recommendations from the American Academy of Optometry's India chapter. And Dr. Susan worked so hard towards, because Susan knew that Raji was such a deserving candidate. And as you would see in this CCLRT newsletter that got published in December 2020, Susan made it possible for Raji to receive her posthumous diplomate. And Raji has now joined along with the rest of this prestigious diplomate group from all across the globe. And that's the whole coverage that you see here. And this is Raji's certificate. So overall, it was, I'm sure that Raji would be sort of cherishing this moment from wherever she is right now. But most of us, like those of us who worked with Raji, we have all gratitude. We owe all gratitude to Dr. Susan Gromacki for making this possible for Raji, because this is what Raji dreamt of, and this is what Raji would have cherished throughout her life, this whole diplomate journey. And so extending that gratitude to you, Dr. Susan, on behalf of the Optometric Association of Tamil Nanbargal, where we consider Raji as our prestigious asset, we continue to consider her, and we are celebrating her life and legacy. And on behalf of the entire Indian optometry fraternity, we thank you. And at the same time, I take this opportunity to welcome you to the first Dr. Rajeswari Mahadevan's memorial oration to speak to us on contact lenses fitting for keratoconus. Over to you, Dr. Susan.
Thank you so much. And of course, it is my absolute pleasure to be here to recognize such a wonderful colleague and person. So let me go ahead and share my screen here. Let's do this. Okay, does everybody see the slides now? Perfect.
Yes, yes, Dr. Su.
So today's topic will be something, a topic that I've been focusing much of my career in, which is keratoconus, and also a topic that I shared a love for with Dr. Raji, as she and I were both very interested in the study and the prescription of contact lenses for any condition, and in particular keratoconus. I have some disclosures, but obviously today I am not promoting any products. I do not have anything that I will be talking about that I have any affiliations with on that front. And before I get started, I would like to just thank 3 groups of people. I want to thank Dr. Rizwana for inviting me and for all of her work on this program. 2, I would like to thank all of you for attending. And 3, and most importantly, I would like to thank Dr. Raji for being the person and doctor that she is, but also for the inspiration that she continues to be. So let's proceed with the lecture. I have written much on keratoconus. I have lectured internationally on keratoconus. Lots of background I have in the condition. Starting back in 1990, in my first year of optometry school, I had the fortune of being the first and only employee of CLEC, the Contact Lens Evaluation in Keratoconus, which to date has become the largest study of keratoconus, 1,209 patients. And it was my absolute pleasure as a young student to be working on this with research giants such as Dr. Joe Barr, Dr. Carl Zadnik, Dr. Tim Edrington. And that really started my love for keratoconus. And after that, I pursued a master's degree in physiological optics, and I wrote over 200 pages. My research project was on keratoconus. So my love for keratoconus goes back a long way, and I'm so excited to talk about it today. First, let's talk about the background. Before we start talking about the actual fitting of the lenses, let's talk about the CLEC study, which basically had the goal of being the first and only study to really follow patients who had keratoconus for an 8-year period, and to prospectively characterize the changes in vision, corneal curvature, corneal status, for example, corneal scarring, and quality of life in patients with keratoconus, and then determining the factors associated with these changes over time. In order to be included, the patient had to have one of 3 characteristics on the slit lamp to ensure that it was actually keratoconus and not something else, not forme-fruste keratoconus, not pellucid marginal degeneration, anything of that sort. So they had to have either Fleischer's ring, Vogt stria, or corneal scarring. So in general, when you're looking at a patient, about 86% of keratoconus patients will have a Fleischer's ring, about 65% of Vogt stria, and about 50% corneal scarring. Now, this is the part of the study that, knowing Joe Barr the way I did and working with him very closely on CLEC, and he was also my advisor for my master's thesis, I knew that one of the motivations for him to want to start this project was a study by Don Korb. Dr. Korb did a study in 1982 where he fit from scratch 14 keratoconus eyes. He fit 7 of them exceedingly flat, touching the cornea, and he fit 7 of them steep, vaulting the cornea. Back then in 1982, there were no scleral lenses. Now we can vault the cornea with a scleral lens. In the past, we had only corneal lenses. So he and many other doctors at the time had the hypothesis that we were creating scarring in the cornea by fitting these lenses too flat. And he was absolutely right. His study showed that 0 out of the 7 eyes that were fitted steep developed scarring. but 4 out of the eyes that were fitted too flat developed scarring. So, the ironic thing is that the entire profession's fitting philosophy for corneal lenses for keratoconus was based on a study of 7 patients. But a lot of doctors had thought of this over the years. And CLEC had 1,209 patients. So they studied this over an 8-year period. However, the US National Institute of Health did not want this to be just a study of fitting contact lenses. So the CLEC study studied the patients over an 8-year period. It did not try to duplicate Korb's study, although they wanted to initially. So what the CLEC study found was that with corneal GP lenses, on average, keratoconus patients were fitted too flat, 2.86 diopters flatter than what was called the first definite apical clearance. So that was the first lens going in 0.05 millimeter increments that actually cleared the cornea. And then they looked at the numbers of these 1,200 patients. 31% of the eyes with flat fitted GP contact lenses had corneal scarring, but only 9% of those fitted steep had corneal scarring. So in some ways, this study, even though it wasn't a study from scratch, fitting these lenses, it did show that Korb's research was correct. We can't ignore the genetics of keratoconus. There have been 75 genes to date that have been isolated regarding keratoconus. And there are plenty of studies internationally that show that there is a genetic predisposition. The CLEC study itself, which was published in 2008, found that 18% of keratoconus patients have a direct family relative, father, mother, brother, sister, child with keratoconus. In New Zealand, that number was 23%. And the prevalence in first-degree relatives is 3.34%, which is 15 to 67 times higher than the general population. Now, there's actually a test, a genetic test for keratoconus. It's a cheek swab. It's made by a company called Avellino Labs. It's called Avogen, and that is available in many countries. And this can be done on people that we suspect have keratoconus. It can also be done on family members of people with keratoconus. So this is really a burgeoning industry now with genetics, and in particular with keratoconus. Patient counseling is very important. I see about 10 keratoconus patients per day. I've really built up my practice through referrals, and it's my joy to care for these people because they really come to see me very worried, concerned that they're going to go blind, and they don't know what to do. One thing I don't do is blame the patient, because we know for sure now there is a genetic component. I always thought that, but now that we have all these tests and we have the Avogen, we know that is certainly genetic. However, not everyone that has the genes or the combination of genes has keratoconus. They might have high astigmatism, high myopia, they might have pellucid, they might have something very similar. So there's an environmental component, including what a lot of people have thought over the years, which is eye rubbing. But in my opinion, eye rubbing does not cause keratoconus. It may exacerbate it, it may thin the cornea, it may contribute to scarring the cornea, especially for rigid lenses in there, but it's not the cause of keratoconus. So that's the first thing I do, because a lot of patients come to me and the other doctors they have seen over the years blame the patient for causing the keratoconus or making it worse. That's tough to live with. So I help counsel them. Also tell them that glasses simply are not going to be working for their condition, and that rigid lenses are likely required for good vision. And that's where I come in, is to fit those rigid lenses. They always want to know how quickly it's going to progress, and we don't know the answer to that. It's unpredictable. But one thing we do know is that the cornea does cross-link with age. And we'll talk about a procedure called corneal collagen cross-linking, which kind of accentuates that cross-linking, but it does stiffen or cross-link with age. And then the other thing, again, is I counsel them, I reassure them. The keratoconus in most cases is not blinding. and to address their concerns. So going back to the genetic component, I get this question about probably once a week, once every 2 weeks, is what caused my keratoconus? Is it genetic? And the way I answer that is everything is a combination of genes and environment. And for our purposes, I think we as eye doctors need to start thinking about keratoconus more similar to diabetes or glaucoma. They're not just one condition, but a group of similar conditions affected by both genes and environment. And I consider keratoconus to be the same. Okay, now let's talk about the management strategies. Early on in the condition, early keratoconus, patients can wear spectacles and they can see quite well. Also, patients who may not have progressed that severely can wear spectacles. I have a couple of patients who were diagnosed in their 50s or 60s, which is quite late. Most patients are diagnosed in their teens to early 20s. The later they are in the diagnosis, the better the prognosis. And those people can wear spectacles, maybe not for their best vision, but certainly for at nighttime, they're relaxing at home, they want to watch TV, they don't need perfect vision. They can put on some spectacles and give their eyes a break from their contact lenses. Also, earlier on in the condition, patients can wear soft contact lenses. But what I find in my practice, I don't know if you find in yours, if you see a lot of keratoconus patients and have them referred in, is I find a lot of patients were fitted in soft toric lenses, disposable soft toric lenses, and they're really not doing a good job. So only early on in the process can they go with these types of lenses. And then of course, gas permeable contact lenses are going to be the mainstay for the treatment of keratoconus to help our patients see better. And we have corneal lenses, and now for the past 15 years or so commercially, we've had scleral lenses, which have been just a huge benefit for these patients in my practice. Then we have corneal collagen cross-linking. Now, as we're diagnosing keratoconus earlier and earlier with both topography and simply listening to the patient, hearing some of their symptoms and doing the right tests, doing pachymetry, measuring corneal thickness, and of course, genetic testing, we can maybe consider cross-linking these patients even before we fit them with contact lenses. Although traditionally, because cross-linking is somewhat new, at least in our country, I know it's been around in Europe for a lot longer, 20 plus years. In the US, it's only been FDA approved by our US FDA for just a few years. So we had always fit the lenses first, but now maybe we can cross-link first and prevent the keratoconus from getting worse. And then lastly, surgery, corneal transplantation. About 10 to 25% of our patients need transplants. So again, soft contact lenses really don't mask much corneal irregularity. If patients are sensitive to rigid lenses, certainly this can be an option, or for patients that play sports. So for early keratoconus, what we can do is we can start with just a standard gas permeable design. This is one that we design ourselves. We choose the curves, we choose the diameter. There are keratoconus specific GP lenses, which are better for say the moderate cones. Also for early cones, there are keratoconus specific soft lenses, not the off the rack disposables, daily disposables. These are lenses which are meant to last 3 months. And then there are hybrid contact lenses, such as pictured in this image here, with a gas permeable center and a soft skirt. So lots of options for early keratoconus. Let's start with the corneal GP lenses. Fitting philosophies. The most common would be the 3-point touch. And when I say 3 points, I mean 1, 2, 3. This doesn't look like a great fit. If you put this in a textbook for a regular normal cornea, this would not be a good fit. But for a keratoconus patient, this is an excellent fit because of the way that his or her cornea is curved. This is about as good as you might get for some patients. Basically, you want to make sure that you have adequate edge lift, which you do, this little strip here of fluorescein. No matter what you do, you're probably going to have a little bit of mid-peripheral bearing. This isn't too bad because there's just a touch of clearance. On this side here, there is a little bit of bearing. There's a slight feather touch centrally and then pulling all around. This is a very typical fit for keratoconus and an adequate fit. Now, look at this one. Some people like to fit a large, flat, gas permeable lens. If they have read the corpse study, they probably wouldn't want to do this because look at that scar right there. Now, who knows if this was caused by the fit, but it's there, and you certainly don't want to exacerbate that scar right there. This is not my personal fitting philosophy, but as the COLLECT study showed, most patients are fitted about 3 diopters too flat. And why is that? Because the patients love it. If you, what I call crunch the cone, you can actually give them a little crisper vision than if you vault the cone. So patients love it. Doctors like me don't love it because I don't want to cause that. So you can go with apical clearance to avoid touching the cone, which is certainly healthier and safer. But with this type of clearance, the patients are not going to be happy with their vision. And you can fit in just a traditional GP lens and aspheric base curve. The lenses tend to be a little bit steeper and they can align with some corneas better, showing less mid-peripheral bearing. So as you can see, this particular lens doesn't show any mid-peripheral bearing at all. So that's an advantage because you're not locking down on that mid-periphery, but sometimes you end up with quite a bit of corneal touch here. Obviously, it's not a real severe touch. There is just a touch of fluorescein underneath, but it's a large area. So again, this is not my personal philosophy. And if you want to get real picky here, the edge is lifting off. So to me, that would show a little bit of discomfort for the patient. And also when you have edge lift, there's the chance for the lens to pop out, which is a problem with fitting corneal lenses in patients who tend to be moderate to severe keratoconus. With the early cones, it shouldn't be too bad. Here's a picture of a keratoconus specific soft lens. This one has high molecular weight fluorescein obviously in it because it's a soft lens. And you can even see there's a little bit of touch with the soft lens, which isn't as much of a problem, obviously. It's not going to scrape the cornea. It's not going to cause SPK. Now, these lenses do provide much better vision than your off-the-rack disposable soft contact lenses. And the main reason is that they're thicker. So when they're thicker, you do get a little bit of fluorescein in between, a little lacrimal lens in between the lens and the cornea, and that does aid vision and can protect the cornea. The other nice thing, unlike the ones off the shelf there in your disposable set, is the parameters are whatever you want them to be. You can order -30 if you want to. You can order 8 diopters of cylinder. You can order 8.12 diopters of cylinder, and you can order axes around the clock at 1 degree. So this really does aid in the vision. And because they are a little bit thicker, they're a little more stable. They tend not to rotate as much. And most of our keratoconus patients do have considerable astigmatism. Examples are the Novacone, Flex Lens, and Hydrocone. So these have a place in my practice, although with scleral lenses, much less of a place than they did 10 to 15 years ago. Hybrid contact lenses have been around forever. Basically, they have a gas permeable center, and now they have a silicone hydrogel skirt. Synergize is the only company, to my knowledge, that produces this type of lens. It's really kind of an interesting technology. It started out with the soft perm years ago. The soft perm lens did not have a very high oxygen permeability. It had a lower DK for both the rigid center and the soft skirt. Synergize took over their own technology in 2005. Soft perm kind of died, and Synergize came in and invented their own lens, which is definitely a better lens. And they started out with Synergize A, Synergize KC, Synergize Clear Cone. Ultra Health is their latest innovation. It's been around for a while. And this is what Synergize recommends people fit for keratoconus. Even though there are actually are 2 keratoconus lenses, they're earlier generations, so they recommend Ultra Health because it has a higher DK of the GP center, 130, and it has a higher DK of the silicone hydrogel skirt, which is 84. So it's a more comfortable lens and it's a more healthy lens. The other advantage to this lens compared to the earlier generations, whether it was soft perm or the earlier generations of the Synergized lenses, is it has a reverse geometry back surface. So that mid-peripheral curve does start to flatten a little bit again and then steepen. So this lens will not tightly bind down on the cornea like some of the earlier generations would. We had problems with lenses like this in that it's very difficult for patients to remove them. And if that center rigid part is sort of stuck onto the cornea, it's even more difficult. So they have sort of reinvented the design of the gas permeable lens so it won't do this. The other advantage to the Synergized lenses as compared to the soft perm is there's a stronger bond between the gas permeable lens and the soft lens. They used to rip, and they're very expensive lenses. So the advantage to this is they don't rip or tear as much. They do occasionally, but very infrequently. And then the other advantage that they came up with the Ultra Health is for each base curve of the lens, there are 4 skirt radii to choose from for the soft lens. So again, that soft lens is less likely to bind down and be too tight, which was the problem in the past. It comes in a variety of powers, +10 to -20. This is one reason why it's not great for advanced keratoconus, is because it only goes up to a -20. And it does have UV blocking, UVA and UVB, and it can be coated with the tangible hydropeg, which is a soft gel-like coating that gives any gas permeable contact lens a little additional comfort and repels deposits. And now this type of lens can be ordered empirically. In the past, it could only be done with a trial set. Now, if you have good data from your topographer, you can give it to the company and they can make the first lens for you. So that's an advantage. The negatives are the same as they always were, even with the earlier generations of hybrids. And the number one that I see is the potential for non-compliance. This is a lens that does deposit, especially considering you have a soft lens skirt that does deposit up. Silicone hydrogel materials deposit very readily with lipids, although they don't deposit very readily with proteins at all. So there's the potential for non-compliance. This lens is made to be replaced every 6 months. And I see patients coming into my clinic, they're a lot older than that, for sure. They're over a year old, and the lens, especially the soft skirt, is tremendously deposited. And with that, the lens does tend to bind and stick too tightly, especially when it's deposited. And patients really don't get the proper instruction, or they forget, and they don't clean it well. And that's a huge problem too. Synergize recommends a silicone hydrogel lens to be cleaned in hydrogen peroxide. And you can't use gas permeable lens care systems because you have that silicone hydrogel lens. So the gas permeable systems are out. They're going to be too strong, too abrasive for that soft skirt. So they recommend hydrogen peroxide, and we have patients soaking it in whatever, and that causes toxicity. And I see patients come in wearing this type of lens with extremely red allergic eyes, and that's not good either. But it's really an interesting technology, and it can be used for early to early moderate keratoconus. So let's go through the initial steps of moderate keratoconus fitting. So if you're going to be fitting with just a regular set, not a keratoconus specific design, but a regular set of contact lenses, how do you choose that? Well, your initial base curve should approximate the steep keratometry reading, or slightly steeper than the average of the two if you have much astigmatism. If you don't have a topographer, that's okay. We fit these lenses for years without one. You can actually extend the range of your keratometer by placing a plus 125 diopter spectacle trial lens over the opening, and then you add 8 diopters to the drum reading. I always use anesthetic with corneal GP lenses. It really helps tremendously in preventing the patient from tearing. And when the patient is tearing, that can affect their vision, your over-refraction, and the lens can move to the side. So I put in anesthetic, let the lens settle, and then over-refract. In general, because you're never going to get a perfect fluorescein pattern with moderate or high keratoconus, what you want to do is just avoid frank apical bearing. So you want to avoid any severe touch. And you would ideally want to see adequate mid-peripheral pulling, although we don't always see that. We see the 3-point touch most often. And you want to avoid any decrease or heavy increase in edge lift. Obviously, the increase in edge lift can cause the lens to dislodge with the blink. It can also be less comfortable as it impinges upon the eyelids when the patient tries to blink. And then if you have reduced edge lift, that's not good because it can cause that lens to bind to the cornea and cause 3 and 9 staining. So you want to start out with a small overall diameter between 7.5 and 8.5 millimeters. And with that, you're going to have a much smaller optic zone diameter than you would have otherwise, between 6 and 7 millimeters. The optic zone diameter should approximate the base curve. So the higher the keratoconus, the more severe the keratoconus, the smaller the number on the base curve, 6.0, and the smaller the optic zone is going to need to be. And generally, because the cornea has quite normal peripheral curve measurements, and actually it has quite normal peripheral corneal thickness. That was actually the topic of my master's thesis, was corneal thickness in keratoconus. You're going to need many curves. You're going to need at least 4 peripheral curves to be able to match that cornea, because the periphery is basically the same as a normal cornea, but the center is just so much steeper. Secondary curve should be about 1 to 3 millimeters flatter than the base curve. Here are some examples of a typical order. 6.5 base curve, 7.5 secondary curve, 9.0 third curve, 11.0 fourth curve, 15.0 peripheral curve with a heavy blend so the patient will not feel those junctions. The center thickness for eye health should be as thin as possible, but at least 0.1 millimeter thick, because you don't want that lens to break, especially when the patient is cleaning it. And material should be a high decay material, again, for best health. If you're going to do a lot of these like I do, you really should purchase a modification unit to add peripheral curves, to blend and edge. And I find a lot of my patients want the lenses to be polished every 6 months to 1 year. So this is a great service to offer. Now, if you don't see as many patients as I do, if you don't see 10 or so per day, and you feel like you're not really gaining the experience in saying, okay, and if you don't have time in clinic, like most of us don't these days, we're seeing more patients in less time. Let's take a look, and I'm going to put you on the learning curve here so that you can actually see, so you won't have to go back and experiment in clinic. So this is a moderate cone, and I've selected a 7.3 base curve and an 8.7 diameter. Okay, so you can see the 3-point touch. 1, 2, very light central touch. 3, the edge lift looks pretty good. Although inferiorly, as you can see, it's a little bit more, and that's very typical for keratoconus. Now, let's go on and look at a 7.2. So now we've gone 0.1 steeper. It looks a little bit nicer, doesn't it? Still have the 3-point touch, but when you go steeper with the base curve, the entire lens will steepen up. So you don't have quite the lift off inferiorly as you did in the last picture. But when you go steeper though, you do crunch the cornea a little bit more in the mid-periphery, so you'll have more mid-peripheral bearing. Now we're going to go steeper still. Now we're clearing the cornea. You might imagine there's a little less clearance here centrally, but there is clearance. But when you keep going steeper, you're going to cause more mid-peripheral bearing here. This to me is not an adequate fit anymore because there's too much mid-peripheral bearing. You're crunching the cornea 360 degrees, although the edge lift does look pretty nice. And here's the 7-0 base curve. This one, again, now you're getting more harsh mid-peripheral bearing and too much clearance centrally. The patient also won't like the vision here either because you're not gently touching the cornea at all. So to summarize, here you have them side by side. So if a patient came with this fit, it's not too bad, the 7.3. What I would do is I would probably steepen it up one step. 7.2 looks beautiful because you have just a little bit of a feather touch, so that will keep the patient happy. You're not crunching the cornea, and the mid-periphery looks acceptable. 7.1 isn't half bad if the patient's happy, but I don't love this mid-peripheral bearing. And then, of course, the 7.0 is way too steep. However, there are corneal GP lens designs specific for keratoconus that can really automatically help you with all of those curves. So a very popular one is the Soper cone. It's a very old-fashioned design. I don't use it a whole lot, but it is very popular. It has 5 curves, and it's trying to fit with some apical clearance. This is a Soper cone, exactly the way they want it to be fit. So with that apical clearance, you will in turn get some mid-peripheral bearing. One of the unique things about this lens is the secondary curve is 7.5 millimeters for almost all the different base curves. The Corv lens has a 3 peripheral curve system. The optic zone diameter is only 5.6 millimeters. So with a patient with a very large pupil, this might be too small. There's a lens called McGuire, which has 4 peripheral curves. It's also fit between apical clearance and alignment. There's one called the Comfort cone. Let me go back here. Somehow we got, there we go. Comfort cone has a peripheral tri-aspheric curve generated by computer lathes. There's a Menicon decentered optic zone, which is really a great idea technologically because most cones are actually decentered slightly inferiorly. So they put it decentered about 1 millimeter inferiorly, and they have about 4 spherical curves in the back surface. There's a Nikon, which has 3 separate base curves and 1 peripheral curve on each lens. There's the Rose K, which is probably the most popular of all. I use this one quite a bit. It has an optic zone that decreases as the base curve steepens. It has 5 to 6 computer-generated peripheral curves blended to simulate an asphericity. And it has 3 edge lifts to choose from, flat, medium, or steep. So most of these lenses, including the Rose K, are what I call cookie cutter lenses. You really don't have much control over anything other than the base curve, material, and diameter. And in Rose K's case, you do have a little bit of control over the edge. Versus designing it exactly yourself, you can choose whatever curves that you want. Then Rose K came up with a Rose K2 aberration control, which is supposed to be better for vision. So this is the one that I use. It varies the eccentricity across the back optic zone diameter to reduce spherical aberrations. And then it minimizes the difference between the curves on the front and back base curve of the lens to lessen or eliminate the blur circle on the retina. Increased aspheric posterior optic zone diameter minimizes the number of focal points occurring along the visual axis. So again, this is what the company recommends using now because it simply is better for vision. Now, as you go into advanced keratoconus, you're not going to see a great fluorescein pattern, no matter what you do with the corneal GP lens. So you're fitting for vision and you're fitting for comfort. You're not going to fit for your own purposes, trying for a healthy fit. So it is a very difficult fit. As the keratoconus progresses, again, you're going to need to steepen up the base curve and decrease the optic zone diameter. And it's not going to look pretty. Look at this. Here you have a 5.8 on the left, 5.8 base curve on an advanced cone. It is still bearing on the cone. And look at that large zone of mid-peripheral bearing. You could call this 3-point touch, but as you can see, there's just a little circle here of fluorescein. So you're really not getting very good fluorescein pattern here at all. If you want to steepen it up, so you're not crunching the cone, potentially causing some scarring, try a 5.75. But look at that harsh mid-peripheral bearing. This is the Rose K. This is what I call a cookie cutter lens. So there isn't much else you can do with it, except for you can change the edge. You can flatten the edge up a touch. It looks a little bit better on the right. It doesn't look great on the left. This edge lift is not going to be enough. You will cause some SPK due to the fact that it's not lifting up enough. The other issue with a small edge lift is you're not getting the fluorescein underneath. Or you're not getting the fluorescein, you're not getting the tears underneath. And in this case, when you're not getting the tears underneath, you're not getting the fluorescein, and you're gonna see that it's bearing here. So you open up the edge lift, you're getting a little bit more fluorescein underneath. But in my opinion, this on the right is a better fit. It's not a great looking fit, and it's not necessarily a very healthy fit. So let's steepen it up even more. Same lens, 5.75 with a 1 flat. What if we go with a 5.65? Because we don't like this touch, because we know that this could cause scarring someday. So you go up to a 5.65, much better centrally, but look at that mid-periphery. It's really crunching it too much. That is not an adequate fit at all. That is not going to be comfortable. It could bind to the cornea, causing lots of issues. So it is tough to fit advanced keratoconus with corneal GP lenses. The good thing is we have some special technologies to help. Most of the labs now can give you quadrant specific technologies so that if you have excessive edge lift, which happens a lot in cones, because the asymmetry of the cornea, we know for a fact. In general, you have about a 0 reading of eccentricity inferior, a 0.3 nasal, a 0.6 temporal, and a 1 superior. So if you want to add a quadrant specific edge lift, such as down and to the right, this can really help you out, not just at the edge, but throughout the lens. So if you compare the upper left pattern to the lower right, there's no doubt the lower right is a nicer looking and also a healthier fluorescein pattern, because you don't have that large area of touch centrally, and you don't have the mid-peripheral bearing, and you don't have the reduced edge lift superior and the increased edge lift inferior. So being able to just tuck in that lower edge helps a lot throughout the entire lens. Here's another example. Rose K has something they call ACT. And what this asymmetric technology does is just change the edge in 1 meridian. So here you have the Rose K2 IC, which is a larger lens than the Rose K. And you can see that it's pulling too much inferior. So as a result, patient's going to feel the edge sitting on the lower lid, and it could very easily dislodge with a big blink. It's also less comfortable. Grade 1 ACT simply tucks in this one edge. The lens is weighted with prism, so it knows where to go. And you just affect this and look at the difference. This is a tremendously good edge lift. This one on the left is excessive. And you've kept the same base curve and same diameter, but it just looks like a nicer fit overall, because now it's centering up, it's not sitting on the lower eyelid, and you're getting the optic zone where you want it to be, which is central. I don't piggyback a whole lot because, to be honest, the oxygen now has to pass through not 1, but 2 lenses. But this is a technology that's certainly out there if you need it. So it's a GP lens placed on top of a soft lens. And the soft lens can ensure good movement and coverage of a corneal GP lens. You definitely want to choose a high DK silicone hydrogel material, and you want to choose a low power. What that does is it shifts the apex to the center of the cornea. If you wanted to choose a moderate minus power, that would be good because you can get some of your prescription in the soft lens as well. This can be more advantageous to an advanced cone where the myopia is quite high, but the low plus power actually helps the lens center a little bit better. The GP lens over it, again, because of the DK issues, you want to have a hyper or high DK material. You want to take an over keratometry over the soft contact lens to decide what your diagnostic base curve is going to be. You want to look for good centration and good movement. You want to see a light apical touch on the soft lens. The advantage to this system, obviously, is the rigid lens is not rubbing up against the cornea. So if you're seeing some central SPK from that, this will eliminate it for sure. And you also want to make sure that it's not too steep in any area, so there's no bubbles in between the lenses. The advantages, of course, is you're going to reshape the corneal contour, could make it a little easier to fit, increases the stability of the GP on the eye, less likely to dislodge, increases the comfort for sure, and less mechanical trauma to the eye. The disadvantage is, of course, decreased oxygen to the eye. So if you're going to use this, you definitely want to minimize the wear. It's expensive because the patients likely will have to purchase silicone hydrogel daily disposable. The soft lens tears easily because these patients have been using GP lenses for years and they're used to rubbing very, very hard to clean it. And if they try to clean a soft lens, they're going to find it's going to rip with their method. They're going to have to readjust to a much softer rubbing. And then it's just inconvenient. In some cases, you can use hydrogen peroxide for both, but if you want them to use a GP lens cleaner and care system, they can't use it with the soft. If you want that soft lens to last more than one day, if it's not a daily disposable, you want to use a 2-week lens, a 1-month lens, they're going to have to rub that every single day to clean it. And what are they going to use? They're going to use a soft lens system. It's generally not compatible with a rigid lens and vice versa. Piggyback care, again, GP lenses are contraindicated for soft. So you can use a GP system for GP, soft for soft. You can use hydrogen peroxide for both. It is US FDA indicated. I'm sure it's the same in India, that the Clear Care and Clear Care Plus are both approved for both gas removal and soft lenses. But as you know, with the hydrogen peroxide, we may or may not trust this with everybody because patients may take their hydrogen peroxide bottle and think they're tired, they want to wet their eye with it, and now you've put hydrogen peroxide in your eye. So we have to be careful who we give this to. And then you could try soft contact lens solutions for both. It is compatible, but it is not approved by the US FDA for sure. I'm not sure about your governing body in India. It works fine for some patients, but obviously, if you wanted the best cleaning, you would go with the GP system for the GP and a soft system for the soft, but that is pretty inconvenient and it does lead to non-compliance over time. Large diameter corneal GPs, like the one that I showed in the previous picture, the Rose K2 IC, these can be used if the cone is large, for example, an oval or a globus cone. These types of cones obviously are less common than the nipple type of cone. If you have a steeper cone, so you're having problems with retention, if there's an inferior apex, this works well because your tiny small diameter lens, especially for advanced cones, is going to decenter where the cone is. That always happens. And if it does decenter, patient's not looking through the optical center of the lens. And if they're complaining about monocular diplopia or ghosting with the contact lenses. So these lens designs tend to be between 10 and 12 millimeters. They're not scleral. They're not landing on the sclera. They're actually landing gently on the mid-periphery of the cornea. It's generally not my first choice. In fact, these days with scleral lenses, it's not much of a choice at all, but I just wanted to let you know that they're out there. And here's an example. It is a very large corneal lens designed specifically for keratoconus, better centration than the small corneal lenses. And with that comes enhanced vision and increased retention. and they have a larger optic zone. And because of that, the patient will experience less flare and glare, especially at night when their pupil dilates. They do have minimal movement and, fewer worries regarding hypoxia or tear exchange these days because we have high decay materials, but you are not getting oxygen around the lens as you would with a smaller diameter. So smaller diameter corneal GP lens will provide more oxygen to the cornea, obviously. What are you looking for with the fluorescein pattern? Again, it's not going to look perfect. So you want minimal touch over the cone. This is good. And you want to avoid excessive clearance or bubbles. Sometimes you can see bubbles in here, bubbles at the edge. And of course, you want to see adequate edge lift. As you can see, this particular case, it's a little bit increased inferior, but the patient wasn't complaining and the lens wasn't dislodging. So this is a very good fit. It's a little bit less here, nasal and temporal, than maybe what you want to in an ideal condition, but it's good enough for me. Now, scleral lenses have really ameliorated a lot of our issues with fitting because even though they're not easy to fit, you're not running into those same issues of the bearing, of the dislodging, of the SPK. So let's talk about sclerals. We all know the benefits of scleral lenses. Because they have an increased diameter, they tuck underneath the eyelids and the patients don't feel them with the blink. They're actually much, much more comfortable than the corneal GP lenses, but they're even more comfortable for some patients than soft lenses. They're very comparable to a soft lens. Because they land on the sclera, technically they land on the conjunctiva, there's increased centration and stability and increased retention. And one thing that corneal GP patients complain about all the time is if something gets underneath the contact lens, it feels like an ice pick. They have to remove the lens, rinse it, and put it in. With the scleral lens gently embedding into the conjunctiva, a foreign body simply can't get underneath, which is great. So it's a much more comfortable situation. It also increases eye health. You will not have, unless it's a poorly fit lens, you will not have SPK or 3:9 staining like you do with a small GP lens. It vaults the cornea, bathing it in tears all day long. So this is also a great option for dry eye patients. Let's talk about the optics. It's made of a gas permeable material. Again, I like to choose a high decay material because, like the larger corneal lens, it's not going to provide any oxygen benefit around the lens. All the oxygen is going to need to come through the lens. Now, something that is really not talked about a lot, but I find is so beneficial to my patients is the larger the lens, the larger the optic zone diameter. So if you have a 15.0 millimeter lens, your optic zone diameter is 9.0. That is sometimes larger than the entire corneal lens that you might fit. So a 9.0 optic zone, for example, is tremendous optically, especially at night for night driving. So many of my patients, when I switch them over from a corneal GP to the scleral, one thing they notice right away, these keratoconus patients, is I can drive at night, which maybe in the past they weren't able to. Also, something that goes a little bit unspoken is the tear film actually provides some optical correction. So with vaulting the cornea like you do, you're going to fill it with a sterile solution, and the tear film will eventually, after about 8 hours, exchange out with that solution. And the tear film actually kind of fills in the corneal irregularities, which you certainly have with keratoconus, helping correct the vision. So let's talk about the fitting now of scleral lenses. You want to vault the cornea entirely. You do not want to touch the cornea anywhere. You want it to rest on the bulbar conjunctiva or scleral. Again, improved comfort, stability, and retention with this. Topography is helpful, but not mandatory. In the US, about 30% of optometrists have a topographer in their office, so that's not a lot. You can start with your central case. Most of your lens design, follow the fitting guide, will tell you where to start. It'll tell you the first base curve or sagittal depth to start with. Sometimes they say use your own gross subjective impression, meaning that you decide whether it's steep, flat, or moderate and adjust the base curve from there. You're going to fill the lens with a non-preserved artificial tear or saline, and you're going to dip in the fluorescein strip right into the bowl before you insert the lens. I insert the lens myself. By the time I could get my staff member to help, the lens is already in. And the key thing about scleral lenses is you give yourself the most diagnostic information if you let the lens settle for 20 to 30 minutes, because scleral lenses actually settle into the conj and sclera minutes, days, and even perhaps 3 months into it. The conjunctiva is quite spongy, so you need to wait about 20 to 30 minutes. That gives you the most information. Ideally, you'd love to wait 8 hours, but you're not going to have your patient sit there for that long, obviously. So 20 to 30 minutes, and then come back and check the fit. And what you're looking for, it all depends on the lens brand, and they'll tell you what they want, but it varies from between 100 to 400 microns of clearance. You want to use an optic section, and what you're looking at is this little strip of green, that's your tears, which are colored with fluorescein, and you want to compare the thickness of the lens, and all good labs will tell you what the lens thickness is of the trial lens, because you don't always know the thickness of the cornea. Most people don't have an OCT in their practice to know that the cornea in this exact spot is 500 or 550 microns. So you want to know what the thickness of the contact lens is, and this little strip here, you want to compare it to that. 400 is generally pretty excessive. Most companies are not going to recommend that. 100 is pretty low because on average, a scleral lens settles about 80 microns over the course of the day. So 100 to me is cutting it too close. Plus these lenses are quite expensive. So 100 doesn't allow any wiggle room in case the keratoconus progresses. You want to look at the mid-periphery to the limbus and make sure there's clearance. I use cobalt blue light for this. And then you want to look at the periphery and make sure that the edge has alignment and no liftoff and no vessel blanching. If the vessel is blanched, it means you're impeding the flow of the blood, and that's not a safe fit. This is a great looking fit right here. So you have clearance throughout. Limbus looks great. There's no redness there, so you're not crunching the limbus, and you want to look at the edge 360 degrees, and you follow the blood vessels, and you want to make sure this blood vessel does not stop. If you have a white area in here, that means the edge is way too steep or too tight, and you want to affect that. So this is a good looking fit. Let's talk about corneal collagen cross-linking for a minute, because this may affect our fitting of the contact lenses. What CXL does basically is it uses UV light to stiffen the cornea. It prevents the progression of keratoconus and other ectasias. So you have an eye drop that's placed in the eye, riboflavin or vitamin B2. You're placed underneath for about 30 minutes. And this is the Dresden protocol that was invented in Dresden, Germany in the 1990s. So like I said, this was available in Europe very early on. In the US, it's been a little bit later, but we have now approved one of the methods with our US FDA. So it is now proven in our country to be safe and effective. Put the eye drops in every 5 minutes. What this is going to do is produce oxygen radicals. And then what this does in turn is induces collagen cross-links between the collagen fibrils. So you've seen this picture before, I'm sure, many times. Here's your fibrils, here's your increased cross-linking, and with that comes increased strength, less flexibility, and it locks that cone in place so it cannot steepen over time. Let's talk about fitting contact lenses after cross-linking. If you read most of the literature, it will say to wait 2 weeks to 4 months prior to the fitting. But of course, this is procedure dependent. This is contact lens type dependent, and it's also surgeon dependent. So listen to your surgeon, ask what they recommend. When I say it's procedure dependent, in Europe, almost all of the cross-linking is called epi-off, meaning that the surgeon scrapes the epithelium off prior to instituting the riboflavin eye drops and the UV light. In the US, there's been some experimentation. It's not FDA approved with Epi-on, because the problem with Epi-off is you can get some haze there. And unless the haze is treated right away, it can be permanent. However, with the Epi-off method, which is the Dresden protocol, you get more bang for the buck. It actually works a little bit better because removing the epithelium helps the penetration of the riboflavin into the stroma, deeper into the stroma, and you get more effect. But of course, with the scraping of the epithelium, you know that cornea is going to take at least 1 week to reepithelialize. So you are going to not want to fit a contact lens for at least a week, if not longer. So you can fit soft contact lenses earlier on in the process, 1 week, 2 weeks. The problem though is that most of these are going to be soft torics because our patients have astigmatism. As that cornea heals, they have found after cross-linking, 3 months later, it could still be sort of changing prescription. I've been burned where I have fit a soft toric lens. The patient has purchased the box of 6. The prescription and astigmatism and axis have changed after cross-linking, and they've had to purchase a whole nother box. So this is not always the wisest thing, is to fit the soft contact lenses. But obviously the corneal GP lens, because of the cone, you will be slightly touching the cornea the way most of us fit the lens, hopefully not crunching the cornea. But you've got that epithelium that was removed. So this is going to be something that's going to be later in the process, maybe 3 months later, maybe 2 months later. In some cases, maybe some surgeons are following, or you're following the post-operative, and it could be more than 4 months later. Anytime there's a combination procedure, such as CK conductive keratoplasty, which is an experimental procedure in our country, it was FDA approved to correct hyperopia. The problem is putting several probes into the cornea to sculpt or reshape in the cornea, reducing hyperopia, it's not permanent. So what some surgeons are experimenting with is not approved by our FDA, is they use the CK around the cone to try and resculpt the cone, and then they lock it in with the cross-linking. That's a little risky in my book. If you look at it, you will see several scars in the cornea. Sometimes the patients can see them as well, especially in a low light, dim situation. Intacs, not FDA approved in our country, but what a lot of surgeons will do is they'll place Intacs are FDA approved, but they're not FDA approved in conjunction with cross-linking. So this is, again, a riskier procedure. It's less stable initially. So again, you want to make sure you have a healthy anterior segment. Many have been wearing contact lenses, even though we didn't tell them to. Many have been wearing them because simply they can't see with glasses after cross-linking, and it may be their old lens, which may not be fitting great anymore, but usually it still does. And then you need to tell the patient that refits may be required, specifically if they wear soft lenses and soft torics. So after cross-linking, you always want to begin with a brand new refraction, brand new topography, brand new case. The fitting should be no different than non-cross-linked patients, unless the cornea and or the refraction change in the future. So for me, after cross-linking, scleral lenses are my standard of care. Number one, because there's more wiggle room. What I mean by that is the cornea may still change. And most of our labs give us a 3, some of them even a 6-month warranty where you can swap out that lens free of charge. So it gives us a little more reassurance that if the cornea does change, we can swap that lens out and the patient will have to pay for another lens, which they would with a soft toric lens, for example, or one of those specialty soft lenses for keratoconus. The other advantage is that it vaults the cornea entirely, resting on the bulbar conjunctiva or scleral. So this protects the cornea, particularly if it's an epi-off procedure and you're very worried about that new epithelium healing. So scleral lens fitting after cross-linking, the secret is it's really the same. as before cross-linking, to be honest. You just have to make sure that the epithelium is healed up before you start. So Epi-on, I used to work with a surgeon who did only Epi-on, and he would send me those patients right away. I didn't even have to wait a week. He sent me them right away. Now, if they're Epi-off, you want to wait at least 1 week, if not longer, depending on your surgeon, for the epithelium to heal. To be honest, in most patients, you don't have to wait 3 months. You know, these patients can't really see well with glasses. So most doctors will give you the patient pretty quickly, at least 1 week, but probably 2 or 3 weeks, maybe a month. But 3 months seems a little excessive. Be careful though with fluctuations. However, with sclerals, there's sort of this inherent built-in safety net. There's something unique about sclerals. You fit them after cross-linking, their cornea may flatten a little bit over time, especially if it's epi-off. In general, the cornea should stay about the same. That's the goal. But with epi-off, you will see even a little bit of flattening, a little bit of reduction in myopia, but there's something about the optics of a scleral lens that you would be surprised at how few times the patients actually need to change their lenses after cross-linking. So that is a good thing, because these lenses, as you know, do tend to be quite expensive for the patients. Corneal transplantation, obviously this is the last resort, and it happens in about 10 to 25% of patients. But I will share with you some new research. First of all, when does the patient need a transplant? When there is poor tolerance, fit, or vision with the contact lenses. Now, this is an interesting statistic. This is an old study, but it still does ring true. About 77% of patients sent to the corneal surgeons that patients and or their referring doctors thought were ready for surgery were actually sent back to the optometrist to fit a contact lens. So that's interesting. I get referrals like that all the time. Now, this is the new data, which is really awesome. With our 2 new technologies for keratoconus, number 1, scleral lenses, because you're not touching the cone. Going back to that Corb study of 7 patients, scleral lenses show 1/5 the rate of transplantation of those who do not wear scleral or GP lenses. So that is tremendous. So we may see that number 10% to 25% go down even more, which is great. And cross-linking also. There's a 25% reduction in corneal transplants in the years following the introduction of corneal collagen cross-linking. So this is really great news, because transplants, any surgery has complications. Transplants induce considerable astigmatism. And what happens in transplants for keratoconus is, we talked about the genetics of keratoconus. I'm going to bring this all back into it. The keratoconus remains in the peripheral cornea when the central cornea is transplanted. So most of our keratoconus patients after transplantation will steepen back up over time, necessitating several contact lens fits, new prescriptions, and then in about 20 to 30 years later, possibly a regraft or retransplantation. And that's just something that if we can avoid for our patients, that is a good thing. So we really have tremendous new technology. So in summary, with our new knowledge of the contact lenses and the keratoconus condition, we have more and better way to help our patients both now and in the future. So thank you so much for your time and attention. It was my absolute honor to present this lecture in memory of our colleague and friend. Thank you so much.
Thank you, Dr. Susan, for that wonderful session on keratoconus fitting. It was an honor to have you here with us on this day. And thanks once again for sharing your valuable time and knowledge with us. Dear participant, you can still post your questions in the chat box, and the questions will be taken at the end of the session. Yep. Now I request Dr. Anuja Singh, Education and Co-Committee Member of OATN, to introduce our own optom, Ashwin Sawaji, sir.
Thank you, Tamir. Yeah, after that scintillating session by Dr. Gromacki, then we move on to the next session. Well, this optometrist, he doesn't need an introduction. He's a senior optometrist from Nagpur who specializes in the field of contact lens and in practice for the past 29 years. He holds a master's degree in optometry from the School of Optometry, Bharatiya Vidyapeeth University, Pune. A graduate of the LI Shankar Netralaya, Chennai. He is also a fellow of the LV Prasad Eye Institute, Hyderabad, from the first batch of 1992. He is actively associated with contact lens education in India and has been given the lifetime accreditation as a fellow of International Association of Contact Lens Educators, FIACL, for his uninterrupted fellowship for over 15 years. He was a senior visiting faculty for contact lenses at the Bharatiya Vidyapeeth School of Optometry, Pune for 8 years and is now actively involved in practitioner education programs. He is also the senior faculty at Vision Care Institute of Johnson & Johnson, India, a key opinion leader for Bausch & Lomb and Alcon. He was awarded the Best Optometrist of the Year 2011 by Shankar Netralaya, Chennai, the Living Legend by Optometry Students Association of AIMS, and BPOC Ambassador for working towards myopia control awareness in India. His areas of practice are contact lenses in complicated corneas and specialty contact lenses, including ortho-K and myopia control contact lenses. His clinic, Saji Vision Care, has been voted as India's first center of excellence for fitting irregular corneas by David Thomas Contact Lenses of UK. For the love of education, he, along with Optom Nilesh Titte, co-founded the Masterclass Optometry with the intention of making a difference in optometry education in India, and they conduct a lot of education programs and conferences across India. I want to share an interesting anecdote about the Masterclass Optometry. 4 years back, we conduct the FBDO program at Shankar Netralaya Academy. It is a contact lens program where faculty from ABDO UK come and conduct the sessions. And 2 days were over, and on day 3, I got a call from the hostel in charge saying few students have fought their way, they have vanished, they have left the classes. And I was very alarmed and very surprised. Few hours later, we tracked them down and we found that they all had left for the masterclass program, which they had registered for, and they risked expulsion and they kind of went away. So I don't blame them or I don't hold it against them. Such is the quality and the popularity of the masterclass program among optometrists in India. My super senior in college, his boyish looks belie a thorough and excellent, successful professional, and above all, a very compassionate human being. Please welcome Yashwant Saoji, distinguished orator for the Dr. Rajeswari Memorial Session. We are very eagerly looking forward to hear him speak. Welcome, Yashwant, and the platform is all yours.
Thank you, Anuja,
Dr.
and
Susan,
thank you.
can you stop sharing? Yeah, Dr.
Yes.
Susan can.
There we go.
Oh, thank you. Thank you.
So thank you, Anuja, and thank you, OATN, for giving me this opportunity. And what a happy moment for me to deliver this oration in fond memory of Raji, a very good friend. Rizwana, you asked me at the start of the program to share some experiences with Raji. Initially, actually, Raji was just a name to me because she joined college much after I graduated. But then she was a well-known name in the field of contact lenses. And until she attended a program at the Vision Care Institute of Johnson & Johnson at Bangkok. And the ride from the institute to the hotel and hotel to the institute for the next 3 days, that the bond somehow grew. And other than contact lenses, we shared one more thing in common. She had a daughter and she has a daughter and I have a daughter. And I clearly remember the look on her face when she used to talk about her daughter and show me the pictures. And I never really realized, when I became good friends to Raji and as well as with you. So thank you, Rizwana. Thank you very much. And I also recollect the last days of Raji when she was actively corresponding with me regarding the international conference which you guys were organizing. And she said, Yashwant, this time you've got a lot of work to be done at the conference. We want you to take care of workshop on OrthoK and conduct 2 presentations as well. And I remember responding to that email saying that anything for education, anything for Shankar Netralaya, and anything for you guys. So here I am talking about contact lenses post-COVID. And I thought because Chennai is my second home, I call it my second home. So I can be very frank, very blunt. So some of the slides in this presentation is going to shake you up the way you are doing contact lens practice, the way most of us are doing contact lens practice. It needs to change. So sometime, you might find it little offending. Please forgive me for that. So I have divided the presentation into 4 parts. Uh, of course, because the word COVID is there, I need to talk a little bit about COVID, but it's just going to be 1 or 2 slides because all of us are masters of COVID and contact lenses now. We've heard it ample number of times. And then we see some good in Corona. Corona pandemic, of course, is a bad thing for the world to go through. But then there are certain good points. They say that there is some good in every bad. So we need to consider the good points of Corona. It has taught us a lot of things like hand hygiene, taking care of contact lenses. So we will go through a few of the slides on that. And I strongly believe that contact lens practice had to be changed. I mean, days are here wherein we need to change the way we are practicing. And it is just that this COVID has accelerated the whole process of changing the way we practice contact lens in India. And the 4th point is don't die yet, because I strongly believed earlier, and I strongly believe even now, that contact lens is a lifesaver for optometrists in India. Many people don't agree with me. Many people feel with the online sales and contact lenses being available everywhere, the future is in refraction and an optical shop. But I beg to disagree. It is contact lens which is going to keep you alive in your professional field. So under the leadership of Lakshmi Shinde, OCI actually put a team together, and we wrote these pointers to help in optical services and optometry services, how to take care of patients and how to take care of yourself and how to take the precautions so that we don't spread COVID through our practices. Very interesting work that we've done, and it was published in the Indian Journal of Ophthalmology. You can go to the OCI website and get this document and read it. Very useful points. One thing I would also like to share is don't worry about contact lenses and COVID, because only less than 3% of the COVID positive patients showed presence of virus in the tears, and transmission through tears is very, very low. So the risk with contact lens as of now is almost negligible. So patients can safely wear contact lenses in the COVID pandemic. Some of the changes that we did to our practices, the glass barrier, glass being transparent, you're not able to see it, but there's a huge barrier of 5 feet by 3 feet in front of me, which separates me from the patient. So that is my way of protecting myself from the patients who walk into the clinic. And slit lamp breath shields, almost every optometrist today is having this in the clinic. And another very important point, an exhaust fan behind the patient. So when the patient is speaking, all the aerosol that is generated is pushed away from you and out of your practice. So if you're lucky like me to have a place to put an exhaust fan behind the patient chair, I think we all need to do that. So let's see what is good about Corona. Okay, Corona definitely taught us hand hygiene, which we've been struggling to teach all our patients. You need to wash your hands, wipe them clean before you handle contact lenses. But people who become old patients of contact lenses, and they realize that 10 years nothing happened to me, so they assume that nothing ever is going to happen to their eyes, no complications, nothing. And many a times, when you tell the patient to remove the contact lens, the patient instinctively removes like that. And that is the point wherein I tell the patient, no, first you have to wash your hands. So today people have realized that before eating, before touching their eyes and mouth and nose, before handling contact lenses, you need to wash hands. People are taking very good care of their spectacles also. Many people have actually spoiled their spectacles by sanitizing them with alcohol-based sanitizers. So people now are extra cautious. We've really learned our lesson well. We've learned how dirty we were initially and what kind of aerosols are generated through our mouths, and how to take proper precautions to prevent spread of this virus infection. So that's good. And another thing that happened in Corona pandemic, I don't know how many of you contact lens practitioners have realized this, people experimented with their looks, like the way I have done it over here. So people experimented with their looks, and actually I was thinking that contact lens trials would go down. But in the Corona pandemic time, at least my practice saw a surge in contact lens trials. Contact lens sale was down, but there was a definite surge in the contact lens trial. So maybe these patients may walk in after Corona pandemic kind of settles down and may move over to contact lenses. So that's the happy part of Corona pandemic, to me at least. So are we doing it right? As I said in the initial slide of my presentation, contact lens practice, the way we are doing in India, needs to change. And Corona pandemic has just accelerated that change. So how the practice is right now? Now, a little disclaimer here, I'm not talking about expert contact lens practitioners in India, but I'm generally talking about optometrists in India. So 80% of practices are product centric. You know, we see a fancy ad on the TV about a product XYZ contact lens. We see a beautiful model and a handsome guy walking and promoting that product. And we associate contact lens with healthy and good looks and all those things. And then the patients go to the optical shop and say, you know, we want a box of XYZ contact lens. And what the salesperson says, Anna, can you give me -4 XYZ contact lens? This customer wants it. And we sell that product to the customer. I'm using the word customer. This is how 80% or 70% of the contact lens practices in India. Then what happens when there is time for the next change and this patient wants a second set of boxes for her contact lenses? What she does, she goes online and checks prices. And she realizes that Anna would have given 10% discount, and there is a Kannadi Kadai right next to her house, which a Mami is managing, and Mami is willing to give 15%. So Anna loses his business, and this patient now goes to Mami. So when there is a time for third change, what happens? Again, she goes online and she checks Amma's shop is giving more than 25% discount. Now, which is Amma's shop? The Amma John's shop. Now you know what I mean. So currently they are offering 30% discount. So if the practice is going to be like this, the patients would learn to shop from one place to another to see whosoever is giving maximum discount, because we are kind of giving more importance to the product and very less or no importance to professional consultation. So it's an over-the-counter sale, and there is absolutely no client loyalty. Okay, and a lot of bargaining happens. So how we need to change? We need to move over to professional recommendation. Let me ask you all, today if you have fever and you go to a general physician, the general physician is going to do all the tests, and he will say, this is the diagnosis and these are the medicines which I'm prescribing. Go to the pharmacy and buy it. And he charges for his recommendation. He's not charging for the medicine. Similarly, you're a professional, you're a consultant. When a patient is coming to you for your professional advice about what contact lens he or she should wear, your job is to do the examination and reason it out with the patient, what contact lens he or she needs to wear, and charge for the consultation and not for the product, right? So of course, more chair time is involved in consultancy. But then the good part is you can charge for your consultancy. That is exactly what I'm trying to say. I remember in one of the programs wherein I was an educator, there were a group of 10 optometrists who had come from India as one of the topmost optical chain. And they said, we are not going to fit contact lenses because it needs a lot of chair time. Well, you cannot afford to fit contact lens because it needs a lot of chair time, and you're not charging for the chair time. If you're going to charge for the chair time, you're actually sitting on this chair to give your consultancy, to give your advice, and then charge for that advice, which you're actually not doing. And that is why you cannot afford to give your time to the patient. You're busy refracting and selling eyeglasses. So charge for consultation, and competition will never affect you because you can never be what I am. You can, of course, have your own loyal patients, but no matter how much my competitors try to steal my patients away from me, they cannot do it. Try stealing a patient away from my practice. You will not be able to do it successfully. Of course, 20% of the patient are, they are not very loyal to practices, but 80% of my patients will come back for my professional advice. More referrals. When these patients are talking to other people who are potential contact lens patients, they end up saying, you go to that fat guy. He's very good. He gives excellent advice. This is what we want. And satisfied patients, and then as a professional, you're satisfied as well. So the future of contact lens practice, or are we in the future? I think we are in the future. This is where our practices need to move. Our practices need to upgrade from regular contact lenses into specialty contact lenses. And the days are changing. Patients these days, don't mind wearing eyeglasses. 15 years back, I remember if we delayed delivery of contact lens to a lady staff at her office, she would actually bunk office and not afford to be seen wearing eyeglasses. But today, people don't mind wearing eyeglasses, right? So practices generally are moving to occasional use of regular contact lenses in the sense, not specialty contact lenses. So it's occasional wear. Sometime I want to wear glasses, sometime I want to wear contact lenses. The specialty practice is on the rise because the instruments are excellent. So, and the awareness about keratoconus, irregular corneas, and myopia control is increasing. So we are diagnosing more number of keratoconus and irregular cornea patients. So specialty practices, the need for specialty practice is definitely increasing. And we definitely have to work a little harder as compared to 20 years back. 20 years back, the contact lens practice was a little bit easier, but I guess they had their own challenges. But here we really have to work hard to earn our buck. And just see this picture here. Now, do you think this contact lens will be available on Amma John's shop? I don't think so. This patient is definitely going to come back to me forever. So there is a weak area here. There is a thinned out area here. And the patient is happily wearing lenses for last 3 years. We all need to promote contact lens. Everybody talks about increasing the footfall in the clinic. Don't talk about increasing the footfall. If you want larger share of pie, then you increase the size of the pie. So what do? Promote contact lens. Talk to everybody about contact lens. Talk to a person who is not wearing any refractive correction. Now, what good that would do, I'll tell you. So multifocal daily disposable contact lenses. Now, these are moving very well in my practice. Now, anytime you have a girl coming in for contact lens, the mother is simply sitting there in the attendance chair, reading your certificates and the posters and looking at the interiors of your practice. Now, what do? You have another staff of yours talk to her about multifocal contact lens, which she can use occasionally. Now, it depends upon how well you counsel. And the mother soon would be more excited about her own contact lens rather than her daughter's contact lens. So when they came in with one pair of or one patient, but when they go out, you're given contact lenses to 2 patients. And multifocal contact lenses are excellent devices to reduce a person's age from 45 to, let's say, 35. And people are opting for it very regularly at my practice. Now, I talk to grandfathers and grandmothers about myopia control. If you attend a conference and if you hear talks about myopia control, they talk about counseling the parents. Yes, counseling of parents has to be there. But if you talk to a grandfather or a grandmother about myopia control contact lenses, these people have gone through the trouble of taking their son to various eye care practitioners, talking about myopia, changing their glasses every now and then. And now an ophthalmologist is telling them that their son has got a complication due to myopia. So they are more worried that these things should not happen to their grandchildren. So what they do when I counsel them, they go home and they play my advertisement in their house on a loop. So there is discussion in the drawing room, on the dining table, at the dining table, inside the bedroom about myopia control and contact lenses, and they are advertising my practice everywhere. So on the right, you see this picture. We had organized for a group counseling at Nagpur, wherein about 100 patients had attended this session. And I had invited Dr. Nitesh Barot to talk about myopia control. And we had excellent conversion rate. I think about 7 people opted for myopia control, ortho-K contact lenses. So growing with contact lenses, the secrets are very simple, okay? Convey a professional image. Now, when students ask me, when you counsel, patients listen to you. But when we counsel, patients don't listen to you, not students, the fresh graduates. Because the counseling is happening at an optical shop behind the optical counter. No patient is going to listen to you. You have to have a consulting room. You have to have a proper table. You make the patient sit there and you show the tools which the companies are kind enough to share with us, or you make your own PowerPoint presentation and explain everything to the patient, and the patient will definitely listen to you. And I really believe in saying this to everyone. It should be a clinic with an optical counter and not an optical shop with a small clinic. So when you have a good clinic, patients will listen to you. You discuss about their contact lenses and you show them posters. Everything has to happen in your consulting room. Regular contact lenses, well, the practice has to be there. It's a contact lens clinic, so you have to dispense regular contact lenses. But if you're only limiting your practice to regular contact lenses, your professional days are numbered because of online sales, because of home eye examinations, because of refractive surgeries. Everything is going better and better. So you use technology to explain a lot of things to the patient and make yourself important in their contact lens life. So online, the product is available, but contact lens counseling, nobody can take that away from you. And make sure you fit all types of contact lenses, because rather than earning from a set of monthly reusable lenses or quarterly reusable lenses, you have to earn a little bit from everywhere: specialty contact lenses, myopia control devices, RGP, keratoconus fittings, regular contact lenses, and whatnot. And another thing I want to tell everyone is, if you're doing excellent job, you automatically tend to believe that patients will refer more patients to your practice. That doesn't happen. Unless and until you request for referrals, referrals will not come. So make sure when you have a happy patient, tell them to refer patients to your practice. Tell them you're doing excellent job, you're doing different practice than others. You look into the eye and decide what lens is going to be safe for your requirement. And a lot of counseling goes into it. So if your friends and relatives wish to wear contact lens, we are the right people for it. Talk to your local ophthalmologist, and if ophthalmologists are not willing to refer, go to pediatricians. Talk to them about myopia control devices, and they would be more than happy to refer patients to you. We get a lot of patients from pediatricians, and we get a lot of patients from special educators for our binocular vision clinic. So why specialty contact lenses? Well, who's going to give this effect? Would any Anna or any Mami or any Amazon will give? No, I don't think they can. Now, this patient was done in 2018, and it was again done by Dr. Nitesh Barot at my practice. She was having -7 spherical with -1.25 cylinder, and she's specs free. And these are her topo map. I mean, this is her topo map for the right time. So why I told you in the earlier slide, if you believe in doing refractions and selling eyeglasses is going to fetch you a lot of money, you are mistaken. Because of online sales, they're getting better and better every day. 3D printing of eyeglasses, so you take your measurement of facial measurements, select the frame design, and the spectacles are printed along with the lens. So that's going to come in the future, or I think it's already being experimented. Home vision testing and surgeries, I've already told you. Regular contact lenses have almost become an over-the-counter product. At the most, the patient will come to you once for a consultation. Once the patient has a pack of contact lenses with her, then she's going to buy that online, unless you tell her the importance of regular follow-up. So basically, you have to kind of show your importance in her contact lens life. So in specialty clinics, some of the products I've listed down, which you can actually practice: keratoconus designs. So as the earlier speaker talked about various keratoconus contact lens designs. So in India, sadly, and the good thing is people are aware about rose-K lenses. Sadly, they believe rose-K is the only contact lens for giving clear vision to keratoconics. You can design your own lenses, and there are a lot of options for keratoconus fits. So keratoconus lens designs, bitoric contact lenses. Nobody does bitoric contact lens in India. At least as far as my knowledge goes, very few people fit these, and we fit them on regular basis. Multifocal RGP contact lens, again, very few practitioners in India are fitting these lenses. Orthokeratology lenses we've been fitting for last almost 15 years for myopia correction. Myopia control, we started fitting about 4 years back. Then in sclerals, you've got mini sclerals, full sclerals, toric sclerals, multifocal sclerals are also available these days. and other products like color blindness, then prosthetic contact lenses, soft multifocals, and bandage contact lens. Now, bandage contact lens is not the contact lens which is available in any lab as a bandage contact lens. We manage the case based on the pathology. So ophthalmologists refer cases to us, and we manage the case using different designs of contact lenses, different fitting, different materials. So some of the contact lens, they draw water out of the cornea. Some of the contact lens provide more than sufficient oxygen to the cornea. So use your regular contact lenses and treat any ocular pathology, and it works beautifully well. Any guesses about what contact lens this one is? You can type in your responses in the chat box. Have a look at the fit and tell me what it is. So how to start? In case if you've not already started fitting specialty contact lenses and you wish to start, it's a very easy way. Co-manage the case in the initial stages of your practice, specialty contact lens practice. Take the first step. You read up about the topic, gather as much knowledge as possible about the topic, and then you talk to an expert. I'm sure you would know a fellow professional or a close friend who would actually be fitting those lenses. Get in touch with him or her, get pointers, or get him to co-manage the case along with you, right? Organize talks. I mean, this is something that I've realized the hard way. When we launched orthokeratology in India, if I remember, it was 2006 or something like that. We had organized a program in one of the best hotels in Nagpur, and about 150 people attended that talk. And we thought we were going to get excellent number of patients from this talk, and nobody came. They were very excited about orthokeratology, but no patient actually converted and started wearing orthokeratology, barring one or two, I think. And that is when I realized, in Hindi, they say, you know, ghar ki murgi dal barabar. And I'm from Nagpur. So I am telling about a product. Of course, they're happy to receive that information. But for some reason, I later on believed that if I get an outsider, the impact is going to be much better. And that is what I did. I invited Dr. Nitesh Barot. He happened to be in India, and we organized a program at Nagpur about myopia control and binocular vision. And 100 people had attended, and I told you 7 or 8 converted into myopia control protocol. And then we started doing this at regular intervals. Of course, every time you cannot get an outsider speaker, but in the practice, we invite the parents. Sometimes we do group counseling, sometimes we do one-to-one counseling. We invite both the parents and the child, and we talk about myopia or any other specialty product that we're dispensing. Industry experts, now every industry, every corporate would have their own professional team, and they would have trial sets with them. So invite them to your practice, collect patients, see how they do the patients, and then later on you take over. Fellow professionals, of course, I've already told you, you co-manage the patient along with a fellow professional who's already an expert in this field. Or maybe 5 of you get together, pool your resources, make a place which is a myopia control and a scleral contact lens or a specialty contact lens practice. And with that pooled resources, you buy only one trial set. So not everybody has to have a trial set with themselves. So it's a special place about specialty contact lenses. Your resources are pooled, your expenses are less. Outsource the back-end management. Now, this is something that has been working beautifully well for few practices outside of India, and we plan to bring this to India. So there is a team of experts who's taking care of the back end. So you see the patient in your practice, you give the data to this team, the team would analyze the data and design a contact lens and supply that to you. You fit the contact lens. So patient only interacts with you. Back end is managed by some other team. And for the moment, I just want you to remember this logo. I'll talk to you all about this logo a little later, maybe a couple of months later. Subscription versus down payment. Now, this is a very interesting slide. My colleagues and my friends in the UK, and I'm sure in the US also, they would be having this subscription method, wherein the way we charge a down payment to all our patients about specialty products. Now, they have a subscription model wherein the patient ends up paying something like 200 or 250 pounds per month. And a complete package of myopia control or scleral contact lenses delivered to the patient, which includes the initial examination, the contact lens, and the contact lens can be changed if the power changes or if the fitting changes. The contact lens is changed and it's a part of the package. So patients are also very happy because they're covered for next 1 year or 2 years, depending on the package. In India, obviously, there are disadvantages because we know what's going to happen if we give it on subscription basis. I don't want to say it out loud, but I'm sure in India it's not going to work. So what we do is we charge upfront and we encourage them to pay using a credit card. And the bank can then charge this as an EMI option rather than a one-time charge. At the most, your practice can take care of the interest that the bank is levying to the patient. Okay. So again, it's a package deal, and we do a package for 2 years. There is no subscription involved. But during these 2 years, all your examination, follow-up visits, change in contact lens, everything is covered. So fees, one of my most favorite slide. Wherever I go, my presentation is always incomplete without talking about the fees that we should charge for our professional examination. Now, earlier times, like 15 years back, when there was, competition is now also, but then that time the competition was free eye testing, free contact lens trial, free evaluation, everything was free, free, free. And that time we used to charge, I think, 200 rupees for an eye exam. And patients used to say, your next door neighbor is giving free eye exam. Why should I pay 200 rupees? And I used to get worried about it. Now, today, what I do is if the patient says for specialty practice consultation, we charge 5,000 rupees. So if I'm charging 5,000, if somebody else is giving the same service as 2,000 rupees, and patient says, he's charging 2,000 rupees, I tell them there is another person who charges 1,000, and this is the address. So I write down the address and phone number and I give it to them. And I also explain why we are expensive, how different we are, and why he should come to us and not go elsewhere. And after that, it's the patient's choice. And I think this method works beautifully well, because when they go home, they think it over and they realize the importance of professional eye examination and they come to you. Ideally, if I have it my way, I would like to have 50% of fees. If the whole product and examination, everything is, let's say, costing 25,000 rupees, I would like 50% of it to be the professional fee and 50% of it to be the product. Now, just to give you an example, when the cataract surgeons do the cataract surgery, they give a package to the patient, which is something like 35,000 rupees. So out of that, the major chunk is their professional expertise and the skill, and the product is very little. So this is what we optometrists need to learn from them, that we need to charge for the professional eye examination. And at the same time, it's not only about charging, it's about delivering as well. So if you're charging 5,000 rupees for a binocular vision exam or myopia control or scleral contact lens, make sure you deliver equivalent to that 5,000 rupees. Otherwise, nobody's going to pay you that 5,000 rupees, okay? So my nearest competitors, in fact, some of them are trained by me. They know my consulting fees and they place their consulting fees 10 to 50% lesser than mine. Still, they cannot break away my patients. Now, another interesting concept which I came across, there are few practitioners, I was talking to a few practitioners from US, and I was interested in knowing, like in my practice, when a patient walks in, a potential patient walks in for specialty product or specialty contact lens examination, the first request is, can I meet with sir for about 5 minutes? So they want to visit me, they want to sit in my consulting room, and they want me to counsel them free of cost about what contact lens and what is the condition and what are the different options. And then they say, we will think it over and get back to you. And sometimes when they have your counseling free of cost, then they end up going somewhere who's charging maybe a bit lesser than you. So I was very much interested in knowing how practitioners in the US are doing. And there was one practitioner who was an expert scleral lens practitioner. And he said, my staff charges them $1,800 before they see me. So whether I fit them with a contact lens or not, whether the fitting is going to be successful or not, whether there would be some problems later on, the refund is only on the contact lens price, not on the consultation. So this is one way of practicing. And another colleague of mine from India, he practices a little differently. On day one, he would just listen to the patient, put on a scleral contact lens in the eye, make the patient read 6.9 or 6.6. The patient is very excited. And once they know or understand the advantages of putting scleral lens in their eyes, once they feel the comfort, once they see the clear vision, they want the product. And then he says, first day, we don't charge. You want this, then you come for a professional consultation tomorrow, and these are our fees. Okay. So for some people, that practice works. For some people, this practice works. See what works for you. So just to give you an idea about what we do in my practice, we experimented with daytime myopia control RGP contact lens. Now this is not delivered, but we experimented, and the patient was very cooperative because that was me only. And toric ortho-K, we've dispensed to a lot of patients and they are happily wearing. By toric RGPs, I told you we do it on a routine basis and patients are very happy. Toric minisclerals, we've dispensed a lot and they are also very happy. And now we are experimenting with multifocal miniscleral contact lenses again on my own eye. Soft lenses, some of the specialty soft lenses that we fitted. I am placing multifocal soft contact lenses here because not many optometrists in India are routinely fitting these lenses. So fit these, they fit beautifully. Everything is about counseling, how you counsel the patient and bring down the expectations and patients are successful. And we fitted complicated powers like these. And this patient was fitted about 15 years back actually. Then we fitted truncated bifocal, which we got from Australia. We fitted original X-chrome lens and the copies of X-chrome lenses which are available in India. Bandage contact lens, I've already told you, and soft myopia control. So 2 of my patients are on soft myopia control. So these are the toys that I play with. These are my sets of orthokeratology contact lenses, and we've got 750 contact lenses in stock. And I can guarantee you none of the distributors would be having so many lenses with them, right? And these are my sclerals and minisclerals and rose K trial sets. And the picture on the right, it's a very beautiful picture. I'm sure you all can guess it's an orthokeratology lens. So what's so special about it? It's the first ever contact lens, orthokeratology contact lens made in India. It did not fit, the experiment was not successful, but I'm sure we will learn from the experiments and very soon we will be able to have lenses which are made in India. So that I think brings me to the last slide, a fond memory with Raji at one of the conferences. And I hope you enjoyed the talk. And I also hope that it'll make you change the way you're practicing. And I also hope that if you're not already fitting specialty lenses, this talk will inspire you to start specialty contact lens practice. So thank you so much. Over to you, Anuja.
Thank you, sir, for the very informative calls for the practitioners. It was definitely the need of the hour session. And I'm sure it was very inspiring, and your recommendation on upgrading ourselves in terms of skills and knowledge, I'm sure is well received by the participants. Thank you, sir. Dear participants, since we are a little behind the schedule, we request you to post your questions in the chat box, and Mr. Yashwant sir could reply to them in the chat box itself.
Okay.
Now it's time to announce the long-awaited Oracle winners and case report writing competition winners. And for this, I request Ms. Divya and Ms. Pooja, organizing secretaries, to do the honors. Over to you, Ms. Divya.
Okay, so we are now at the most exciting part of the session. So before announcing the winners, I would like to take you all through the series of events that OATN has conducted to honor and celebrate the legacy of Dr. Rajeswari Mahadevan. Just a minute. So the first event that OATN conducted was a case report writing workshop, which was held on 17th July between 6 p.m. and 8 p.m. The workshop aimed to introduce the process of planning, researching, and drafting a case report for publication. Our eminent speakers helped the participants to understand the purpose and the basic requirements of an effective case report writing. The workshop was successful with 101 participants. So following the case report workshop, case report writing competition was announced for optometry students and practitioners. Case reports related to contact lenses were asked to be submitted in a given format by 25th of July. The case report that we received were reviewed by 2 independent judges and scored as per the standardized case report evaluation rubrics. The winner of the case report competition under the student and the practitioner category will receive a cash prize of Rs 5,000. All the participants will receive the participation certificates through email. The participants of case report writing competition can reach out to OATN for any help in terms of funding or mentoring support to convert their case reports into publications. OATN will be happy to help you. The next event was first OATN Rajeswari contact lens examination, abbreviated as Oracle, was conducted on 24th July between 6:30 p.m. and 8 p.m. The questions were from 7 important domains of contact lens practice. This platform was open for 3rd and 4th year optometry students to assess their knowledge level and boost their confidence to practice and successfully fit contact lens and manage the patients. Questions were prepared by the education committee members of OATN. The exam was conducted online, timed for 25 minutes, and was auto-proctored. Questions and answer options were randomized, so each student get an individual exam. We had 59 registrations, and of which 43 students were able to successfully complete their examination. The winner of the Oracle will receive a cash prize of Rs 5,000, and the runner will receive the cash prize of Rs 3,000 along with the trophy and the appreciation certificate. All the participants will receive the participation certificate through email. We would like to thank Ms. Saranya, Ms. Tamil Chudar, Dr. Anuja Singh, Ms. Deepa, Dr. Sumeer Singh, Mr. Gopinath, Mr. Vivek Suganthan, and Mr. Siddharth for their continued support to make the event a grand success. I now invite Ms. Divya to announce the winners of Oracle and Case Report competition. Over to you, ma'am.
Thank you, Pooja. So I'm happy to announce the winners of the competition. So first, we would see the winner of the case report competition. Okay, the winner of the case report competition, the runner of the case report competition is Ms. Uma Maheshwari. She's from Aditya Jyot Institute of Optometry. Congratulations, Uma Maheshwari. And the winner of the case report competition is Ratna Bharati Sitaraman from Vasan Institute of Ophthalmology and Research. Congratulations to Ratna Bharati. Next, we will see the winner of the Oracle. So, next slide, Pooja. Hello, yeah. So, the case report competition. Sorry, this is the case report writing student category. Is Akshaya Balakrishnan from Elite School of Optometry. And next is the case report writing competition practitioner category, Aparna Badrinarayanan from Elite School of Optometry. So, Shankar Netralaya. Thank you.
Thank you, Ms. Divya and Ms. Pooja, and many congratulations and best wishes to all the winners and all the participants too. We, the extended family of Dr. Raji, invite her family, Mr. Ganesh, the ever-supporting husband of Dr. Raji, and her lovely daughter, Ms. Ashwini, for this event. And I kindly request Mr. Ganesh, sir, to share a few words with us.
Hello, can you hear me?
Yes, sir, you're audible.
Yeah. Ashwini is not with me because she is preparing for Arangetram on 10th of this month. So she's training hard.
Best wishes to her on our behalf, sir.
Pardon?
Best wishes to her on our behalf.
Thank you. I'll be sharing the live event link to Rizwana, and probably whoever is interested can come online and see her performance, because it was her mother's dream that she wanted to learn probably Bharatanatyam, and the conditions were not right, so she allowed her daughter to pursue the dream. So this OATN case study thing is a very good thing. Like I'm an electrical engineer. I've been advocating that the practitioners or the technical guys who are already into the industries, they should give back to the alumni or the people who are studying that particular topic or case or course or whatever it is. they should give back the industrial experience they have gained. So this is my firm believer, and I'm the firm believer of that. Just about half an hour back, we had a 25-year reunion with our college mates, and I was insisting on this, that we should give back to the institution where you learned, or the people who are learning the same course. So I congratulate the OATN for instituting this, and I strongly suggest to the students that they should catch up on this particular idea and then cultivate the habit of presenting case studies, because I believe the whole contact lens and the practice revolves around seeing patients, unlike engineers who struggle with machines which cannot speak. Okay, so I really appreciate, and I also appreciate the in charge who recommended Raji for diplomat. I'm very thankful for her, and that was the dream. Raji's dream was to be a diplomat, and she in fact she had a lot of she had to see a lot of patients, which is in your language it is case study. So ultimately it boils down to practice in the field. So once again, I congratulate the winners who won the award today, and let your tribe grow. Thank you.
Thank you, sir. Thank you so much for joining with us. And we will, Dr. Susan indeed is expressed her happiness that, Raji got this diplomate. And thank you for joining with us and for all your motivating words. Thank you.
Thank you.
And congratulations to Ashwini for both the Arangetram and for the excellent performance, for the 92% that she has scored up in her +2 exams. So congratulations on behalf of Team OATN to Ashwini.
Unfortunately or fortunately, she is not going to pursue a course career in optometry. I cannot comment on that. Whether it is a bad luck or good luck for OATN or other optometrists, I'll leave it to your choice.
She will grow as a great human being that Raji was, sir.
Yes,
so
yes, that's it.
Yes.
That's it.
Yeah.
Thank you.
Yeah. Thank you, sir.
Thank you, sir. Now we are almost at the end of the session, and now I request Jyoti Balaji, sir, to give the vote of thanks.
Thank you, everyone. I know most of you would have exchanged greetings on a Friendship Day. It's a mere coincidence. This event was organized, and people who are participated, organized, whoever done it, everybody is friends, known to each other, also known circle of Raji and Raji family as well. So it's a mere coincidence. This is what happens when you plan something really good. In Tamil, Thiruvalluvar says, ஈதல் இசைப்பட வாழ்தல் அதுவல்லது ஊதியமில்லை உயிர்க்கு. That means no greater income in life than to live with the fame that comes out of actually immense charity. Or why not we take it like a giving or helping others? This is what has happened actually. You try to give what best you want to give it to people around you in the form of a care, or it can be professional care or whatever care it is going to be. And that comes back to you. Long time before, when we started I Teach program, Mr. Kumaran sir asked me why we didn't invite Raji to give a talk. But that time I didn't had any answer, but I know she was not well. I said maybe on appropriate ground. But see the scenario right now. We are all gathered here to give a oration in her memory. But anyway, it is a kind of mixed feeling. But anyway, it is good. We are all here to pay our respect for our Raji in our own way. Thanks, Rupam Sinha, for recommending the Run for Raji on September 9th as a mark of her memory. And that was something very unique. Okay, it is one of her passion next to contact lens. And it is so nice of you sharing your personal experience and personal relationship, how things where you shared with Raji. And of course, special thanks to Professor Susan, who participated all the way from US in a Sunday early morning and sharing almost every single aspect of contact lens fitting in keratoconus before and after, even CXL, and covering various types of contact lens. And of course, special thanks to Yashwant Sauji, who always puts in a different perspective when it comes patient care or practice management. So once again, I'd like to thank all the speakers and all the winners who participated various event which was conducted around Raji's memory. And also good thanks to all the members who came forward and whatever way they could able to contribute, whether it comes in the form of emceeing or giving introduction to the speakers like what Saranya and Anuja did it. And of course, the event is well conceptualized by our educational committee, and special thanks to everyone. Over to you, Tamil and Rizwana.
As JJB sir said, a big thanks to each one of the OATN members and other participants for making this event a memorable one. Looking forward to taking it up every year in memory of Raji and to live up to her legacy. Thank you, one and all. Over to you, Riz.
That's it. Nothing from my end as such. And it's so very apt that good things happen for good souls. And if you really see, everything happened so well in such perfection for her. And I think this is the
Rizwana, you are muted, Rizwana.
Oh, thank you, sir. So what I was just telling her is that for a great soul like Raji, things have happened in such perfection. And the only way, I mean, this is like the least that we can do on behalf of Team OATN. But as the days go, I think we should keep continuing to celebrate her legacy through such events and through, other innovative stuff like what Rupam proposed. But thanks to all the good souls who joined in unison today to celebrate her life. And also thanks to her family who is continuing to be the torchbearers of her vision and mission, because what I'm really seeing is that they are upholding her values on her behalf and really looking at ways to take her legacy forward. And I think that's really a blessing that anybody can get. And so let Raji continues to bless all of us from heaven like a shining star as she has always been. And let us all continue to celebrate her life in all ways that's possible. And that's all I have to say. And congratulations to all the winners and everyone who stood with us to make this event a grand success, because so much work has gone behind. And so congratulations and thanks to everybody. So that's it. Thank you, sir. Thank you, Yashwant sir.
Yashwant sir has given a wonderful comment. He says, OATN is the best state optometry association in India as per my assessment. Thank you for the thank you, Yashwant, for recognizing OATN as well. Thank you so much.
Thank you, sir. Our senior member, Kumaran sir, is, I think, is so happy to hear this comment from you, sir.
This comment is going on Facebook tomorrow.
Thank you. Thank you, sir. Thank you. Thank you, everybody.
Thank you, one and all.
Okay.
Yeah. Thank you. Thank you, TC. Thank you.